I'm actually now going to turn it over to our wonderful scientific director, Dr. Claire Betker, who said hi at the beginning of this webinar. And she's going to do me the favor and honor of moderating this conversation, which I'll sort of join in with my own 2 cents as a panelist as well. So we've got some wonderful panelists here from Niagara region and Peel region, both medical officers of health and health equity focused staff in different capacities. And I'm going to let Claire take it over from here.
Thanks, Pemma. And hello, everybody again. I'm just going to start by acknowledging that where I am speaking from and working from, have the privilege of working from, the land from which I'm providing this moderation is I'm in Treaty 1 territory, which is the traditional territory of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene people, and the homeland of the Métis Nation, and what is currently known as Winnipeg. And I just really want to respectfully acknowledge that we all have the privilege of working and living in the traditional lands of the many Indigenous people of our country. So I have the distinct pleasure of being the moderator today for today's discussion, and we have about an hour left. Well done, Pemma. You covered a lot of territory there, a lot of information in a quick time, and engaged us in some, I think, really interesting conversations and some dialogue. And so I'm going to start with the panel introductions. And the reason why we switched to this today is so that Pemma can actually bring her perspectives to the panel conversation in the hard work. It was hard work. It was kind of soul-searching work for her and the other co-authors of those 2 documents. And I really encourage you to find those documents. They're short, they're easy to read. They cover a lot of really important information, and we really hope that they're useful to you in your decision-making and in your practice. Okay, so we have some very distinguished guests with us today, and you can see there we have Dr. Mustafa Hirji and Kate Harold from the Niagara region, and we have Dr. Lawrence Lowe and Paula Smith from Peel region, and we're really anxious to hear their perspectives and their reflections today. And we have 3 questions. We've met with each of the folks that are here with us today, the panel, and I'm going to ask them to begin with their own introduction of who they are, the space and place that they occupy, and where they actually are speaking to us from today. And we have sort of 3 parts to this conversation. I'm going to encourage you to ask questions or make points or add to the conversation through the chat box. There's some of our staff from the National Collaborating Center for Determinants of Health here with us today. They can help to gather those questions and comments and respond to you, and maybe even provide some thoughts or some resources. So really, we want to know from our panel, just as we asked you, how values have supported health equity in their organizations. How did that go during the last 18 months in terms of our response and efforts and into recovery and continuing to plan and respond and recover from the COVID-19 pandemic? And then we're really hoping to share and have a conversation and a dialogue about what are better opportunities, or what are those opportunities that are out there to better name, and as the title of the webinar says, align the values with our practice. And I think that shift that we saw between those 2 wordles or word clouds is a very interesting observation from the group here today. So I'm going to start with Niagara region and Dr. Mustafa Hirji and Kate, and I think Kate Harold, and I think Dr. Hirji, you were going to speak first. So I'll encourage you to put your cameras on so we can see you, and how are values that support health equity, how are they named and operationalized in your region? So over to you.
Okay, thanks so much, Claire, and thank you for the opportunity to come here and speak and share and be part of this dialogue. You know, before I start, I just want to highlight that both Kate and I are, of course, speaking from Niagara, which is one of the traditional lands of the Haudenosaunee and Anishinaabe peoples. And we, of course, want to make sure we continue to recognize them, where we've come from. In terms of, the values, in Niagara region a few years ago, we actually put together a health equity strategic plan. It was actually originating with some of the work that the NCCDH did around the 4 roles of what public health should play in health equity. And our plan was really built around operationalizing that. And part of this was we actually have a set of 7 values that we define. And there's a fair bit of overlap on it. I'm not going to read them all out here, but humility, one of the values that Pemma has highlighted that came up in her research, definitely in ours. Another one which I think is really significant is the self-determination value, which Pemma highlighted. And if you actually look at our health equity strategic plan, in our vision, we outlined that our vision is a Niagara where everyone is empowered and has the opportunity to reach their full health potential. So I think it really captures that idea of self-determination. And I think putting that in the vision and kind of setting that as what we are striving for, hopefully tries and sets that self-determination as one of the values that we're all going to be striving for. Another way we tried to really, instill some of that value is, one of our values in our health equity strategic plan is investing in impact. And when I stepped up to being the acting medical officer of health, I had a phrase which was impact on health and health equity, which I pretty much use anytime I speak or in any email I'm sending out to staff, or really whenever I'm, making some sort of big commentary. And that was really to try and keep reinforcing that that is the North Star that we have in our department, that we're trying to make an impact, which is the value, but an impact on health and health equity to really make sure we don't lose sight of that. And I think really stating that over and over again, hopefully helps build the, really the common sense that this is something that we're all striving for together. Another value that I think was really important in our plan is that, again, Pemma talked about accountability as being one of those key instrumental values. And that was really core to what we built. We didn't want to just have a health equity strategic plan that was nice and looked like a great way to approach, but we wanted to actually build in some accountability steps to hopefully push ourselves to getting there. So some of what we did is, in our organization, we actually have what's called the shared performance performance objective. So all staff, when they're setting a performance objective, we actually have one common objective that everybody adapts and then customizes to a little bit towards their role. We decided that common objective we'd all have would be a health equity objective. And it would be a common objective that we all shared, so we'd all see ourselves within this common mission towards achieving that. With our plan, we built, clear, smart objectives and indicators with timelines to achieving that, so we could actually follow through and hold ourselves accountable to achieving that. And I think ensuring that accountability was there is a really key part of our plan. And the final part of our value I just want to highlight is listening to our communities. That was another value that we had, and I think this touches on a lot of the values that Pemma talked about. Things like humility, respect, etc. We framed it as listening to our communities. And when we actually developing the plan, we actually started off with a consultation with a lot of the different communities, particularly some of the more marginalized communities, to hear what they're seeing, some of the services that work with that, and use that to kind of extract what should be some of our objectives, what should be these values that I've just talked about. And then once we put together our plan, we actually went back to them all and had them validate whether or not we're on the right track and then adjust as appropriate. And I think approaching our whole health equity strategic plan by listening to the community to develop it, hopefully sets us up that we're going to continue doing that as we actually implement the plan. So those are a few initial comments on how we've tried to articulate some values and really build that values into how we approach our work here.
Thank you. Thanks. Kate, do you want to add or wait till the next question?
Sure. I was just going to say, well, thanks for that, Dr. Hirji. Yeah, and just, the vision and the guiding principles and the values used to kind of create this strategic plan was to operationalize. I don't know if I'm jumping ahead yet, but it was kind of split into 4 streams of work to kind of guide activities, which has made it kind of clear, which is the part of the work, big part of my portfolio is to kind of coordinate some of that work, and it ties back to the accountability. So we had timelines attached to a lot of activities, which unfortunately had to be amended due to some of the pandemic response work, but that was the last part I wanted to add on, is the streams that were created are very valuable.
Yeah, great, Kate. And we'll maybe have you speak a little bit more in detail in terms of how that played out in COVID. But I'm just going to ask you to say who you are, Kate, so the folks that are with us know what role you play. So just introduce yourself.
My name's Kate Harold. My title is Strategic Initiatives Coordinator at Niagara Region Public Health in Ontario. So I'm speaking from the same place as Dr. Hirji. And I think we're one public health unit of, I think, over 30 to 35 in Ontario, so in Niagara Region.
Yeah. Thanks, Kate. And thanks for, when we put out the call in terms of our planning for this webinar, you put your hand up and said, I think that we at Niagara Region have something to offer to this conversation. So thanks for doing that. Sometimes that's not easy to do, and we really, really appreciate you doing that. So thanks for being here today. So we'll go over to Peel Region for a few moments, and Dr. Lawrence Lowe, and as I said, and Paula Smith are with us. So Lawrence, I'll go to you first. So how are values that support health equity named and operationalized in your region?
So thanks so much, Claire. And before I begin, certainly I'd love to introduce myself, Dr. Lawrence Lowe, Medical Officer of Health at the Region of Peel, here together with Paula Smith, who is our advisor on this important topic, and acknowledging that I am speaking to you from the traditional territory of many nations, but specifically the one covered by Treaty 13 with the Mississaugas of the New Credit, and grateful for the opportunity to serve and work on this, serve the people of this community and work on this land. So it's really exciting to hear where Niagara's journey has gone to some degree in Peel. Our work and constant strive towards equity has been an iterative process over many years, many strategic plans, many discussions with the community and within the corporation and the public health unit. But I think the easiest way to say it is just as the COVID-19 pandemic started to unfold, we actually had released a new 10-year strategic plan in which one of the strategic priorities for our organization was advancing health equity. And this priority was selected for inclusion after a very rigorous strategic planning process that involved meetings with stakeholders internal to the health unit, internal to the regional corporation, key community partners, also the public, as well as other various stakeholders within the healthcare and the public and private sectors. So we actually landed on that. The existence of the advancing health equity strategic priority did not emerge from thin air, but really reflected the previous decade of work on the strategic priority of serving an ethnoculturally diverse community. But that was developed in 2010, and subsequent to that, over 10 years, it was as our knowledge grew and our understanding grew, we recognized that there was a need to really broaden and recognize the diversity beyond just ethnocultural diversity that really impact health outcomes, and obviously disparities and equities there too. So that was our new strategic plan. We had already started throughout the year 2019 a number of an amount of work working with staff, but we hadn't had the chance to land fully things such as a vision, values, all those other pieces prior to just given that the strategic plan had been implemented and prior to the arrival of the pandemic in our community. So to a large degree, at least naming the strategic priority was the first and most important, because it did manage to inform some of the actions and activities that we took in the response and how we approached them. But of course, absent values, it really became sort of trying to build the equity plan as we were flying it, as we were also doing the same with the COVID-19 pandemic. It is worth noting that our documents did name specific values, even if they weren't necessarily not values, but approaches and themes, even if they weren't necessarily intended as values originally. Anti-oppressive practice is clearly named and identified within our 10-year strategic priority, and specifically directed as an area for staff development. And in addition to that, we, once the pandemic unfolded, started to name interim strategic priorities, which were basically the same strategic priorities that we had intended on the decade from 2020 to 2030, but then subsequently fitted with a lens of pandemic response and COVID on there. And in those interim strategic priority documents, given everything that we had seen, we also named stigma and discrimination as another aspect of what we had observed through the response and how that had negatively influenced many of our communities. So the themes have been there, the themes have been there, the priority has been there, it's been named, even if they weren't necessarily presented intentionally as values. And it certainly has been a learning process out of seeing where things have gone. Certainly our health unit being one of the first in the province to start collecting race-based data based on self-reported race and occupation, and then using it to support our ongoing response. Really showing the indirect value of having those things named, even if they weren't intentionally named in the first place as values. Paula, I don't know if you wanted to add on to that at all.
Sure. Thanks, Dr. Lowe, and thank you everyone for having me here today. I just want to quickly introduce myself. My name is Paula Smith, and I'm an advisor here at Peel Public Health. And I'm currently supporting equity and community engagement. And as Dr. Lowe has mentioned, I'm a settler on these lands, and I'm speaking from the region where the Region of Peel operates, which is part of the treaty lands and territories of the Mississaugas of the Credit. I think the one piece that I would want to add to your comments, Dr. Lowe, is that, you know, we really were not ready, fully ready, like many health providers and human service providers, in terms of, you know, being ready to fully respond, thinking about health equity from, you know, arguably one of the largest health crises that, you know, even worldwide has faced. I think one of the challenges that we had is a lot of the work that we had put into motion to support our strategic plan had to be not necessarily paused, but really kind of thought of very, very differently. Many of our staff were seconded to various areas of the response. We were also working with people in our human services and corporate division, and all coming together. So we were all coming together at various levels of skills and understanding. And that really was a challenge in some ways and capacity. So, you know, I think one important thing that has happened working together with different people from the organization, I've been amazed to see that even though I'm working with people who are not necessarily from Peel Public Health, that a lot of these values and themes are coming into play and coming into discussion. Things like humility and especially trust. So, you know, while some of us have not named some of these values explicitly in our work, as Dr. Lowe has outlined, certainly the values have been forced to come to the surface in a really positive and meaningful way.
Thanks so much, Paula and Lawrence. So a couple things that I was just hearing there is around leadership, and, you know, values-based leadership has been written about for decades, and you're all leaders, you know, very significant leaders in the last 18 months, especially around COVID-19, and you know, how values, and Pemma started there, how they influence us as individuals, how they make themselves manifest in society and the context around us, and then how that organizational responsibility to name and put into play values is so important as you go forward. And I also heard that notion of evolution, right? That we have seen rapid growth. That plane has flown, right? You used that metaphor of building the plane as you're moving forward. But there is a real evolution as knowledge grew, as evidence grew, as, you know, you tested waters and moved along. But I wanted to go back to Pemma just for a minute in terms of alignment. So Pemma, as you listen to Mustafa, Lawrence, Paula, and Kate speak, what resonated for you in terms of aligning with that literature and evidence base that you were really immersed in as you worked to write those concept documents that you spoke about before?
Well, thanks, Claire. I think there's a few things that align. I mean, certainly the values that we've heard were both named and not named, but ended up being core to responses are very much in alignment, even if they're not the exact words, with the values that we heard, read in the literature and from others that are supportive of social justice and health equity, and are really in many ways foundational to public health practice. So, for example, that value, the Ottawa Charter talks about communities and love and compassion, and honesty and humility comes up in various different places. And so I think solidarity and reciprocity are also named again in many different pieces of the literature that we looked at. There's too many organizations to name that has prioritized those values. The core competencies, which Claire, I know at one point you worked on for public health in Canada, which are now being, I believe, revised or renewed rather, in their preamble mentioned values like self-determination, and Dr. Hirji mentioned the importance of that. And so I think there's definitely good alignment. The other piece that strikes me is just the fact that like the clarity and the unclarity, the naming and the fact that these values aren't always so clearly named, but do present themselves. And then once they present themselves, it's kind of like chicken and egg, what comes first? Like we're acting and then we're finding out what is the most important. Or can we start from a place of naming what's most important and planning for it accordingly? And Paula's comments of, preparedness at a system level to act from a place of values-driven responses really struck me, because I think that experience was likely not unique to Peel. I think if we were to hear from regional public health authorities and health units across Canada, we would hear the same thing, that I don't think any of us were necessarily ready for this kind of crisis. And certainly when we do act in this kind of crisis, and this might lead us into another question, Claire, I think it's not only human nature, and the literature has validated this, but it's also kind of where we go to in a decision-making place to act from a place of what is our default, what have we been trained to do, and often what we've been trained to do is not to act from a place of complexity and difficult decision-making. Often we've been trained to act like this. 1, 2, 3. This is what happens. This is how we react. And in the organizational development literature, that really comes up in what the theorist Argyris talks about when he compares espoused values, or what you say you value most, versus what you actually do, or your theory and use, and that disconnect that can come up. And so I think that probably is something that many of us grapple with at a time of difficult and complex decision-making, and responding to a pandemic is no exception.